Good day, everyone. This meeting is now being recorded. Welcome to Partners in Care Module 2, the Clubhouse Model. As you will notice, all participants have been muted. If you have a question to ask, please submit your questions in the Q&A pane, the icon of which can be located on the bottom of your Zoom window. Your questions will be answered after the presentation. If you have any technical issues, please send a chat to all panelists and hosts, the directions of which can be found in the chat window. Thank you for joining, and please welcome Dr. Afzal Javed, President of WPA.
Good morning, good afternoon, and good evening. Dear participants, Fountain House New York team, and the speakers and the moderators, facilitators for this course. It is indeed a great pleasure for World Psychiatric Association to be associated with Fountain House New York to run this important course on partners in care. This is a long-awaited educational activity, and WPA is thankful to all the participants, to all the course moderators for bringing this important information for our mental health professionals, family physicians, trainees in psychiatry, and other mental health fields. We have had an excellent module which was completed last week, and this is the second module in the series of this course. The main objective of this course is to highlight the importance of empowerment and bringing our patients, users, and clients to the heart of our management plans. The Clubhouse model is indeed a great innovation, and we really want to promote this model, which is cost-effective and which can be easily replicated even in low-resource or low-income countries. Today's module will give practical aspects of the concept of Fountain House, Clubhouse model, and how we bring the patients to the center of our attention using this particular model. We hope that this module will not only enrich our experience, but will also set new guidelines for helping us to start programs following the philosophy and mission of Fountain House. I would like to thank the course directors, Fountain House New York team, and more importantly, our patients, members of the Fountain House, and all those who are benefiting from the services of clubhouses for giving us an opportunity to work with them and to learn from them, which is helping us in shaping and improving our expertise. Thank you very much, and we look forward for an active participation from all the participants. Thank you very much.
Hello, everyone. I'm Dr. Jeannie C. I'm a psychiatrist in New York City and the medical director of Fountain House. I've been in this job for less than a year now and took it over from Dr. Ralph Aquila, who was the medical director of Fountain House for about 30 years. and who developed in conjunction with our training team this Partners in Care curriculum. It was actually an international collaboration of experts that developed this material, and we're really proud to be able to share it with you today. First, I'd like to introduce, though, we have a wonderful guest speaker today to lead us into the training. His name is Dr. Eric Atchis, and he is an associate professor and directs the Division of Psychiatry and Behavioral Medicine at Michigan State University. He is also the Behavioral Health Medical Director for Network 180, which serves Kent County, Michigan. He has also been an investigator on more than 45 clinical trials in schizophrenia and depression, and has published over 60 peer-reviewed papers. He has served as the president of the Michigan Psychiatric Society, is a distinguished fellow of the American Psychiatric Association. And this is exciting. He was just named the 2022 Physician of the Year by the National Alliance on Mental Illness in Michigan. So we're really pleased to have Dr. Atchis share with you today. Dr. Atchis.
Thank you so much, Dr. C, for the very kind introduction, and Dr. Javed for really setting the stage for this curriculum and for this important work. We so appreciate the partnership with the World Psychiatric Association and look forward to continuing this work with you. I just want to spend a couple minutes just to share a little bit of my story and my exposure to working with Clubhouse and how that's affected my practice. And I guess in some ways I represent one of the target audiences for this curriculum that we've developed. We want to try to identify and partner with community psychiatrists and help them understand the value that Clubhouse brings to the individuals that they're working with, and how it can actually improve and make their practice better and more successful. I was first exposed to Clubhouse back in 2006 during my residency training when I was a resident training in the Boston area. And immediately, as soon as I walked through the doors of the Clubhouse, I knew there was something special about that place. I saw people interacting together, talking, working together. It felt so different from the clinical spaces that I was used to working in. And it really felt like a home. That is, I think, where the magic is in Clubhouses, is in those relationships that are formed. I then moved to Michigan in 2007 and immediately looked around to see if there's a Clubhouse in the area where I would be working. And I was very pleased to find out that we had a really terrific Clubhouse in Michigan as well. It's called Sheldon House. And so I got involved right away because I knew that that was an important partnership and that the individuals that I was trying to serve would be well served also by being involved in Clubhouse. In terms of this curriculum that's been developed, I'm just really excited about it, for a couple of reasons. The main reasons are that it marries, I think, the two most important things in any curriculum: excellent evidence-based research, which has been developed over the years, showing the benefits and the effectiveness of Clubhouse. And then it also includes the voices of the people that we're serving together and serving with, the members of the Clubhouse. And so the way the curriculum is designed is it's meant to be co-presented by somebody who works in Clubhouse or perhaps a psychiatrist like myself, but then also with the members of a Clubhouse. And Lisa Holton is one of our panelists today. She and I co-presented along with others, Tara Van Dyke, our executive director, this curriculum to our residents, our first-year psychiatric residents at Michigan State in Pine Rest and Grand Rapids. And we really just had a wonderful time exposing them to the model of Clubhouse. They were able to tour the Clubhouse, which I think is absolutely essential. And then, of course, the most convincing and most important part of it was having Lisa share her experiences. So I am really delighted by this curriculum. I hope you'll find it to be helpful. I hope that if you have any questions, you'll feel free to reach out to any of us or anyone associated with Fountain House or the World Psychiatric Association. We'd be glad to give you more resources. And with that, Dr. C, I'll turn it back over to you.
Thank you so much, Dr. Atchis, and to both you and Dr. Javed, thank you for championing clubhouses and community-based supports with us. I'm pleased to introduce our panel for today as well. Folks who attended our first module, which is a successful discussion of integrated care and setting the stage for why we need community-based support, sports like clubhouses. We have Kevin Rice, who is the Director of Research at Fountain House, and he presented the bulk of that first module. We also have with us today Dr. Francesca Pernice, who is the Associate Professor of Educational Psychology at Wayne State University. She will be leading today's module and really discussing some of the great findings from her research on clubhouses from the last many years. Dr. Lori D'Angelo, who's the Executive Director of Magnolia Clubhouse in Ohio, is also with us today. She has a wealth of experience firsthand in running and working with clubhouses and making it one of the great community-based supports it is today. With us is also Craig Bayer, a member of Fountain House, who has been key to developing this curriculum as well. And he is also the editor and founder of the Fountain House Roar Journal, an international journal of poetry and writings. Lisa Holton, as mentioned by Dr. Atchis, is with us today, and she's a member of Fountain House. Member of Sheldon House. I want everyone to be a member of Fountain House too, but Lisa's with us today as a guest speaker. We're really happy to have her. And supporting this work and coordinating is Kinga Yenjechuk, who's our Associate Director of Partnership Development at Fountain House. We could not have with us today, unfortunately, Cyrus Napolitano, who's a member of Fountain House and the co-director of the Clubhouse New York Coalition. He usually does with me what Lisa does with Dr. Atchis in presenting to residents and medical students to really let people know how great Clubhouse can be for people with serious mental illness and for the providers working with them. So we'll start off with the presentation, and afterwards, Kevin Rice will moderate a panel discussion with our esteemed panel guests. So I just wanted to reiterate that this is the second in a 3-module series as part of the Partners in Care curriculum that talks about how we can leverage community in recovery from serious mental illness. And this is Fountain House partnered with the World Psychiatric Association, but also the Wayne State College of Education and Magnolia Clubhouse to present this and really benefited from our international advisory board as well. Next slide. So what this curriculum, as Dr. Atchis mentioned, what it was intended to do was to help people like Dr. Atchis and me, psychiatrists in training or in practice, to really understand the world of psychiatric treatment that occurs outside of hospitals and clinics, and one that is very key to the recovery of people with serious mental illness. And I think for me as a resident, just like Dr. Atchis, learning about Clubhouse and seeing it for the first time opened my eyes to how much of people's recovery occurs in the community and how important their relationships and, like Freud said, their lives and work and play are to their recovery. And so today that's what we're going to talk about. And we hope that all the psychiatric providers who are joining us today and mental health professionals will understand the principles and models of integrated care that includes community-based supports as part of the very important puzzle to help people with serious mental illness. Next slide. So while the first module talked about integrated care and set the stage for why community-based supports are important as part of the integrated care equation, today we are going to focus on the Clubhouse model as an example of community-based supports, one that this training team knows best. And we're going to talk about the history, development, and research supporting the Clubhouse model so that folks can understand the evidence for it, and why it is very key to the recovery of people with serious mental illness. Next slide. The learning objectives today. We are going to have Dr. Pernice and Dr. D'Angelo speak with us about the Clubhouse model. What are the programming features and standards? These are international Clubhouse standards that have been vetted over time, and talk about the unique contributions of Clubhouse to recovery. And in particular, we're going to introduce a very important concept called social practice that many people may not know about, but that is key to what we used to call the magic of Clubhouse, how it works and how people get better. We're also going to talk about, this is Dr. Pernice's specialty, the research and health outcomes associated with the Clubhouse model, so that folks can understand why this is so important. Next slide. To just briefly review the meat of what Module 1 was about, we talked about how despite so many advances in the treatment of individuals living with serious mental disorders like schizophrenia, bipolar disorder, and major depression, despite that we have medications and psychotherapies, we still know that people with serious mental disorders die 10 to 25 years earlier than the general population. And they die of the same things that kill most other people, which is cardiometabolic disease, heart disease, and stroke, and diabetes. And that we know that about 60% of this excess mortality and morbidity is due to treatable causes and preventable causes. So that's been a call to arms for all of us in psychiatry to really look at the physical health of the people that we serve. We know that there are many reasons why people with serious mental disorders experience greater morbidity and mortality. And there are many obstacles, including that people with mental disorders experience a lot of stigma and cognitive challenges, including negative symptoms and disorganization that prevent them from getting the care they need. If you're a person suffering from schizophrenia, for instance, sometimes if you show up to a clinic, let's say you have a rash. If I have a rash, because I have a community of people around me, I might show my rash to a friend and say, what is this thing on my arm? What should I do? And my friend might say, you should go to this clinic. I know this nice doctor. And if I go to the clinic, I will probably, be able to go right in, get it taken care of, and that's that. But for many people with serious mental illness, what they experience is that they have a rash. They don't have somebody to talk to about it because they don't have, community supports, friends and family. They've been cut off from those people. Many people who have serious mental disorders are living in the street and don't have those connections. And when they go into a clinic, they experience discrimination because of their positive symptoms, because maybe they're hearing voices or have disorganized behavior. And that rash never gets looked at or taken care of. And what if it is something very serious? And what if we're talking about chest pain or, a paralysis of one side? What can people with serious mental disorders do in that situation? So there are many reasons why people with serious mental disorders don't get the care they need and suffer worse health outcomes. And part of what we've done in the last many years is to look at this question and see how we can better integrate care to support people with serious mental disorders. One big feature that both Clubhouses and many other psychiatric services have done is to fight the stigma around serious mental disorders so that people can be included in society, respected by society, and get the help that they need. Next slide, please. So the focus of this training and even more so of the first module of this training was looking at how the conversation in the last few decades has been the integration of psychiatric and medical care. So before I came to Fountain House, I was 15 years in a community behavioral health agency where we looked at how we can bring primary care into behavioral settings like assertive community treatment teams and clinics and day programs and into psychiatric housing. And also how to bring psychiatric care into primary care practices so that more people could access psychiatric care. However, one piece that I know from my work in those settings to be really important was that, just putting a primary care doctor into a behavioral health clinic did not change the access to care as much as bringing people into a center that they could feel like was a second home, that they could feel like they had friends and people that cared about them who would then encourage them to get physical health care. And so at the last module, I talked about how just having a lunch with folks every week was one way that many people obtained good primary care, physical health care as part of our efforts. And what that taught me was how important building community is. And that is something that Fountain House has been doing for 75 years now, almost 75 years. It's almost our anniversary. And really bringing community supports to the fore helps us to see how looking at where people are employed, whether they are employed, their education around health disparities and about health practices, their relationships with others and who they have relationships with, and what kind of housing, if they have housing, people live in. All of these social interventions are so key to people's physical health outcomes. So if you don't have a place to live, and if you don't have people around you, your health outcomes are very different than if you have an apartment and a job and people who are saying, hey, have you seen your doctor this year? Or hey, can we help you find some healthier foods? And that's what we're really going to focus today. So on the next slide, we're going to introduce the real topic of today, which is the social interventions that can be delivered through a community in the service of integrated care. So the Clubhouse model that Dr. Pernice and Dr. D'Angelo are going to introduce to us today is a psychiatric rehabilitation model that has demonstrated success in reducing hospitalization rates, increasing quality of life, and improving social functioning. And there are randomized controlled trials in addition to other studies supporting these findings. The Clubhouse model we talked about, we just introduced last time and we'll talk about more today, is an intentional therapeutic community. So the design of a Clubhouse is very intentional in ways that will support each person in finding meaning, belonging, and purpose. And that's done using social practice interventions that will be discussed today. Creating community is at the very core of Clubhouse practice. And so the idea is that no one recovers alone. Clubhouses can now, just in the last 75 years, this model has been spread to over 30 countries. And we have over 40 years of research. There are, I believe, 330 or more clubhouses around the world today. So this model has caught like wildfire, I would say, because it is low cost. As Dr. Javed said, even low income and low resource countries can introduce clubhouses in a way that supports our work as psychiatrists. Even in the US, we talk about how limited psychiatry is, and in many other countries it's far more limited. And we need to use community resources to support the work that we do so that more people can access integrated care. With this, I'm going to introduce Dr. Pernice, who's going to take us into the meat of talking about Clubhouse and what it's all about. Thank you.
Thank you, Dr. C. Buongiorno, benvenuti, welcome everyone. I'm Dr. Pernice, and I've had the pleasure of working with Clubhouses for over 22 years. We're going to talk about community in the next slide, please. And what we're going to talk about today is Clubhouses, and Clubhouses inviting people living with a serious mental disorder or illness such as schizophrenia, affective disorders like bipolar or major depressive disorder, to join and become members, not patients, not clients, but members of a community. And for many countries that may be represented here, this is a collective identity. And by changing the language, we support in changing our identities from a patient to personhood. And so the intentional community of the Clubhouse is designed as a therapeutic community, a therapeutic environment that offers folks access to friendships, to social connections, to being included in the community, in their society. It offers opportunities to practice skills, to learn new things, to explore new opportunities. And it also offers a community that improves, through research that we've discovered in many studies, the quality of life for folks and the opportunity to live free of stigma, free of coercion, like being forced into treatment, and an opportunity to become more independent. The Clubhouse does not force people to come. The Clubhouse is based on the philosophy of voluntary membership. You may join, be invited to join a Clubhouse, and other members invite and bring you into the community. Next slide, please. Let me just share with you a little bit of our history. It is not my history to share, but essentially over 70 years. This is not a new idea, although many of the work that we do is innovative, given that it's non-traditional, it's non-clinical in the nature that we tend to understand how psychiatric support is offered. The first instance of this model emerged back in 1944. It started through the hospital setting that was located in the state of New York. It was called Rockland State Hospital. And this was a point in the history of American psychiatry that many people who were living or suffering from mental disorders such as schizophrenia and depression were basically institutionalized and living in hospitals. This was beginning to become sort of the start of people being moved back into the community. And so it really began with people who were living with severe mental disorders, wanting to have a support group and prepare each other to re-enter society. They started meeting on the steps of the New York Public Library, which is pictured here on an old photo, and they called themselves the WANA group. We are not alone. Because the consequences of living with some of these conditions can isolate us, can draw people away from us, family, friends that may not be there when people were leaving the hospital. WANA, We Are Not Alone, later became Fountain House in 1948, and it was founded on West 47th Street, and it's still on near that street. And it was named Fountain House because it had a garden, it had a fountain in the garden located in the building, near the building. It was also the time in 1948 that Fountain House became incorporated and a fellowship was established. Now, I just want to remind folks that this was entirely run and supported by former patients. There was necessarily not professionals that were formally involved, but these were folks helping each other re-enter the community. Next slide, please. Here's a picture of an early picture probably taken in probably the late 40s, early 50s, and juxtaposed with today. Fountain House is still a vibrant community serving a great number of people. And this model, as Dr. C had stated, has been replicated in over 30 countries. Next slide, please. what was not mentioned at the very beginning, that although Fountain House was the first US clubhouse, the actual first clubhouse was established in Lahore, India. And so as the first US clubhouse, it essentially became what folks call it sort of the mothership, the clubhouse that really became the identity for the clubhouse model. And this clubhouse model is referred to an intentional community. We are intentionally bringing people together to engage in some project, activity, task, community. And so it really set the foundation for an international movement that involves human rights, an international movement that involves removing the stigma of living with a serious or severe mental disorder. The social interventions that are now delivered through clubhouse models include interventions that help people to get back to work, to get back to education or school, to have stable and healthy places to live, to have advocacy for their health and wellness needs. And these social interventions are delivered and supported through the entire clubhouse community. And so when we talk about an intentional community, the clubhouse uses the work in terms of meaningful work to support and mediate the relationships between our clubhouse members and our clubhouse staff. And work, and I will talk a little bit more about what this work means. This is designed as the vehicle, the mechanism to support recovery for people living with severe mental conditions. And this work supports community reintegration. Essentially, individuals that become part of our clubhouse communities redefine their identities. They move from being patient to person. Next slide, please. I want to introduce Craig. He is one of our fabulous members at Fountain House, who's going to introduce sort of the structure of the clubhouse model. The clubhouse model has an accreditation body known as Clubhouse International, and Craig has been very active in promoting sort of the standards, the guidelines, and the ethics around a clubhouse community. Thank you, Craig.
Thank you, Francesca. And I just want, forgive me for being a little scripted, but we have some very important points to make. So I'm a little bit, adhering to a script here to describe the standards for you. The International Clubhouse Standards are not just a recipe book for physically creating a clubhouse, but principles for bringing about recovery. And I'm going to address a few of these standards today. One of the standards is standard number 9. That is, the clubhouse staff are sufficient to engage the membership, yet few enough to make carrying out their responsibilities impossible without member involvement. And the purpose of this standard, in order for the member to be and feel needed, the staff is intentionally understaffed. This way, there's plenty of work for the membership to do. The members have no reason to be bored. They are there to serve their recovery and the clubhouse, not to be passively serviced. Another important standard is standard 19. All work in the clubhouse is designed to help members regain self-worth, purpose, and confidence. It is not intended to be job-specific training. One of our favorite standards, it is the essence of the clubhouse. Members are there not to be kept busy or generate profits. They are there for their recovery and to help the recovery community. Therefore, clubhouse work must be done in the service of helping members regain their confidence in working and in their talents and abilities and in their value to the world, and that helps them regain their self-worth. When I visited Mosaic Clubhouse in London as part of a colleague training, the director of clubhouse training at Fountain House, Dr. Alan Doyle, requested me to observe that clubhouse work and see if it honors standard 19. And of course, if you, I visited the clubhouse, and it was a very enjoyable time in my life. And the clubhouse, if you visit it, you will find that it honors standard 19 to the hilt. And I just wanted to mention that Dr. Alan Doyle taught me how to analyze the standards. He's been a very important person in my development. The final standard I'd like to address is standard number 20. Members have the opportunity to participate in all the work of the clubhouse, including administration, research, enrollment and orientation, reach out, hiring, training and evaluation of staff, public relations, advocacy, and evaluation of clubhouse effectiveness. Members participate in all aspects of the clubhouse, and that helps them regain their self-worth, confidence, and dignity, and helps fight stigma and self-stigma. If they only had menial jobs, they would feel insulted and demoralized and would simply quit, especially since this is a volunteer operation. Working side by side with the staff in all aspects of the clubhouse helped build my faith, not rebuild my faith, not only in myself, but in the staff and in the rest of humanity, who I thought would reject or belittle me for having a mental illness. And I just wanted to give a shout out to a couple of people. The biggest fighter for adherence to these standards happened to be Dr. Ralph Aquila, who was formerly the chief psychiatrist of Fountain House, and his current successor, Dr. C, carries on that tradition of fighting for member rights. So that's pretty much all I have to say about the standards. And now we want to discuss in more detail the work order day of the clubhouse. And so I introduce my fellow clubhouse member from Sheldon House in Michigan, Lisa Holton.
Thank you, Craig. Good morning, everyone. The work order day, there is just so much more than what we can present today of what a work order day means. But in essence, shortly, we have different areas that you can work in. As a member, I've been a member of Sheldon House for almost 5 years now, and we have a culinary unit, we have business unit, we have our health and wellness office, we have an education office, we have reception area. It's a very big place. But in the foods, I'll just give you a little overview. In the culinary unit, all the members that are in that unit, and you can work in any unit you want. You're not told, oh, well, we need you here, we need you there. You get to choose what you want to do within your clubhouse as a member. And if you just choose to come and visit and hang out, you can do that too. However, we would like it if you could try some. It's a teaching for them. But in the culinary unit, when they get together, they set meal plans, they do budgeting, they purchase food, they prepare meals, they serve them, they learn nutrition. So that's just an very short thing of what the culinary unit does. In the business unit, it is just as important. We have our reception area, we maintain the wellness welcome center downstairs. We have a copying center, we have banking. We get together and schedule social communication or social activities. We do research for the, TE, the temporary employment. We work with members on housing. There's so much. I could go on and on and on forever about the work order day. But the most important thing I want everyone to understand is these work order days help prepare us to possibly put us more into the future, or to get us out into the public, or get us into some type of employment. And from my personal experience, working within the Sheldon House, and I have worked in both units, has given me an opportunity to further made me see that I was worth more. It was a family that encouraged me. So now I'm supported with education. I'm working very, very hard. I got a technical writer certificate. I'm working with business and marketing because I found one of my passions is supporting the Clubhouse model, breaking the stigma, telling people we're okay. We can do this. We can be productive members of the community. So the work order day is just so much more than what we can discuss today. And like I said, we're not forced to do any of this. This is a member involvement at your choice. And we are treated just as equal among any unit and staff. So like I said, that's a short. I hope everyone enjoys the rest of the day. And I pass it off back to Lori.
Thanks, Lisa. And thank you, Craig and Francesca, for helping us more fully understand the Clubhouse model. As was described, the standards, which were and helping you understand, and the actual operations of the Clubhouse, the standards help define the structure in a practical way to support the philosophy and ensure the Clubhouse operations include consistent things to help this model have integrity to the results that we've discovered when it's done in this way. So Craig described a bit of the accreditation process, and what happens is each clubhouse that's in seeking accreditation evaluates itself in relation to the standards, and they complete a self-study that is given to a staff and member team of the faculty of the Clubhouse model that reviews the self-study and then visits with the clubhouse, as Craig described, and spends time with the clubhouse and reviewing the information they've provided and their daily operations to see if they are fully implementing the model. And that information is then shared with Clubhouse International staff, who evaluate that and determine a level of accreditation. So it's a very replicable process and very well defined. And some of the work order day focus, as Lisa described, some of the activities that happen in the clubhouse, as she described, include preparing food most often. Lunch is an important part of the day. Also enrolling and orienting new members, as was described in the business unit, taking daily attendance. Clubhouses are involved in all of the work that is needed to evaluate their operations and track employment and education, for example, and attendance. Clubhouses have often other operations that are included in the work order day. For example, we have a media lab in our clubhouse, and we provide and create digital media videos that help people understand the Clubhouse model, as well as a daily in-house news show that explains what's going on in the clubhouse and offers an opportunity to share new things happening in employment and education and health and wellness. And clubhouses are involved in the day-to-day functions, including administration, governance, finance, and maintenance. So it's a very rich opportunity to do work inside the clubhouse. But in addition, the work of the clubhouse, as you saw in some of the information so far, includes helping people become a part of the broader community. And one of the primary ways that is supported is employment. So the next slide, please. The clubhouse has historically supported employment. It's been a very key focus from its inception. And one of the unique ways this is done is developing transitional employment positions. And these are employment created with area businesses that become partners with the clubhouse. And in these opportunities, members hold the positions from 6 to 9 months. The clubhouse develops the positions, provides all the training and support, and guarantees job coverage. The members become employees of those companies for that amount of time so that they have an opportunity to develop their confidence and skills to better prepare them for ongoing employment, which the clubhouse also supports. And members of clubhouses, as you will see in our research information, have higher rates of employment because of these supports that are very important to help people go on with their lives. So helping people reintegrate and move forward, so becoming a part of the broader community, is as essential to the clubhouse model as becoming a part of the community within the clubhouse environment. And as Lisa described, we also support people going on in their educational goals. And this can include everything from developing literacy skills to going on in college. We support housing to ensure people's basic needs are met And we are, as you have been hearing a lot, promoting health and wellness to ensure people have proper nutrition, get good health care, and the basic things that we have discovered more recently are very necessary to health and the broader picture for people. The social drivers of healthcare have been a part of this model since its earliest times. So we also are involved in advocacy in the broader community, and that's a very important part of our operations, helping to improve the lives of people living with mental illness. And that, I think, has become more and more organized as the model has evolved to help us make more of an impact. So now we were going to talk more about what happens between the members and staff. How is this work done in terms of the therapeutic role of the staff in engaging members and helping support their growth and recovery? And how is this relationship defined in the elements of social practice? So I'd like to turn the segments now to Dr. Pernice.
Thank you, Dr. Lori. Thank you, Lisa, and thank you, Craig, for sharing your experiences and illustrating some of the core features of the Clubhouse model. I want to circle back to some of the things that Craig and Lisa and Dr. Lori mentioned about the environment. And I want you to visualize what the Clubhouse model really attempts to replicate is a normal business environment. We operate from basic hours, say 9 in the morning to 5 in the afternoon. And between those times, like in any other environment, people are doing and working and engaging. And so it's really modeled after a typical business you might see in your community. And during those hours, a lot of things are happening. People are working together to keep the doors open, to keep the program moving. They offer lunch, they do cleanup, there's writing, there's projects. And so think of it as a business, essentially. So what is happening in this clubhouse that makes recovery possible? What are people doing? Both the members and the professionals, we call them social practitioners now, because we're sort of renaming the ideas that are happening in this environment. And so we've settled on this term, social practice. It's not a new term. It came actually from a researcher in the Netherlands, and it was borrowed, and Dr. Alan Doyle, who was the previous director of the education unit at Fountain House, really began to run with this idea and changing the language and bringing more integrity to the work that is done in this clubhouse model. And so essentially, the methods that are used to develop opportunities for recovery includes programming the structure, the environment, so that we can develop healthy interpersonal relationships and feel like we have a place to belong. Recently, we had another way of thinking about this in terms of social practice being a place where it's conducted by people that give us purpose. And so it really grew out of describing the practices and interventions, what Clubhouse has been doing for the last 70 years, and it brought language to this model. So we're trying to move away from things like there's magic happening, because there is science behind what we're doing. We're creating an intentional place with people and purpose. We're creating a community that nurtures the need to be needed. And we're creating opportunities that enhance our confidence, our self-efficacy, and our recovery experiences. As we go to the next slide, social change, the theory behind it is that it's not just an individual experience, but social practice and the theory of change is really achieved and experienced within this community. Many studies, many research projects have really looked at recovery, for example, from trauma, and recovering from trauma in a community setting. Mental illness does not create some of the experiences that people experience. The consequences of mental illness create some of the disparities that we see. And so we need a community to heal again. And so social practice sets the therapeutic environment. It is what we do. And I'm going to talk about how this differs from hospitalization programs like partial hospitalization that we have here in the US. You may go to a hospital for half of the day, then you come home. But what you do there may be more therapeutic and does not involve you as a whole person, your interests, your ability to work with others, your goals. And the Clubhouse is not a day hospital program. Here in the US, we have these models where folks go again for a couple of hours and they come back, and maybe they stay for a week. The Clubhouse is membership, and membership is considered for life. Now, does it mean that you may be there all the time for the rest of your life? No, but it means that you are a community member, and you may go to any Clubhouse and you're welcomed as a member of that community. Next slide, please. The key assumptions that I want to sort of explain about this idea of social practice that's delivered through the Clubhouse is that a lot of the work, we call it the therapeutic environment, is really designed to assist people by having mutual agreed upon goals. We agree, there is alliance, and you go at your own pace. I am no more of an expert than you are on who you are and what you need to heal and recover in your journey. The second assumption that we have is that recovery is possible. We truly believe this, and we believe that it is something that happens that is very personal. It's non-linear. There's not a straight line. Sometimes we take 2 steps forward and a step back. I often say, I fall 7 times, but I get up 8. And so we all have our personal journey. A third assumption is that social practice is designed to be practiced and positioned within an intentional community setting. Today, we're talking about it within a clubhouse, but these principles and this therapeutic approach could be implemented within other community or social intervention models. And the notion here is that there's a non-hierarchical composition. Just because you have doctor in front of your name does not make you better or worse, for example, that we all come to this community together. And so it allows us to also be aware of cultural stigma, of the influence of power dynamics, and also the marginalization or the exclusion of people who've been living with these conditions, and they have been pushed to the margins of our society. So within this intentional community, everybody is equal, essentially. Next slide, please. And so just really quickly, social practice as a therapeutic model operates and intervenes within 2 levels. There's the organizational level that focuses on space, the design of the space, the different environments that people interact with. And we can begin to look at what some of the experiences are that are happening at the organizational level. The second level that social practice operates is the interpersonal level, or the relationship level. And this is a focus on each person, their strengths, their goals, and how they are designed to meet that person's recovery. And so a social practitioner operating within social practice would engage a member within projects, activities, or opportunities that would promote their confidence, in addition to building trust in that relationship. Essentially, these relationships that members develop with social practitioners evolve to include other members of the community. And so even a member may begin to do social practice in the clubhouse with others. Next slide, please. I'm going to go through the 5 elements as we've designed them and really elaborated with members, staff at Fountain House and internationally. The first one of these elements of the social practice therapeutic model is the social design. Here in this slide, you have a picture of some space. This is a space at Fountain House, and the way in which the space is designed to include people to interact in the environment, to facilitate interactions, relationship building, and essentially to develop a feeling of what Elliot over at Fountain House calls communitas, a feeling of togetherness and belonging. And for those of you who are from collectivist cultures, you understand the sense of community. And this is essentially what the social design aims to do. So it's being very intentional how things are set up, where they're set up, how it creates space for interaction and engagement. The second element of social practice is essentially that, engagement. What will draw you in? What might interest you? Here in this picture, we have this beautiful desk that's located at Fountain House that greets our members when they come in. And behind this desk may be a member checking folks in. Good morning, hello. And it's by promoting this deliberate need to be needed that allows people to feel included and welcomed. No one is forced to come, but if I can come and be greeted in this beautiful space, it engages me. I may have not yet developed those relationships yet, but I'm pulled in by some form of engagement. And so that is a second element of social practice. The third element of social practice we'll talk about here is building relationships. Essentially, at the very beginning, John Beard, who's been associated with the modernization of Fountain House, really established this notion of go out and build relationships. That's what we need. Folks that come to Clubhouse, we understand that may have been living through isolation, may have not had connections with friends, peers, or family. And so part of the core aspect of this model and social practice is increasing support, creating a network of social support, which encourages people to reciprocate that support to others in their community. And it provides an opportunity to help folks build and navigate new interpersonal connections in a variety of contexts. Here in this picture, we have folks in the culinary or the kitchen unit working together to prepare the day's meal. Everybody can come with different skills, and essentially everybody has a task or a job to do together. Now, if this was going on at my house, I'd be happy cooking every day. But okay, next slide, please. The fourth element of social practice, and we've had some different ideas about what to name this. Right now it's called intervention and assessment. And essentially what this means is a social practitioner, the person who's delivering the intervention. They work together with our members. They partner. They come up with ideas on what would support their recovery. They're constantly reviewing, assessing, does this fit? Does this work? What do we need to change? What do we need to do differently? And the feedback is provided in a very naturalistic way. It's in vivo, it's right now, it's in real time, it supports success and it supports our failures. So we can fail, but somebody catches us, and together we can address and assess the challenges and take the risk, because we know if we fail, we have an opportunity to do it again. And so intervention and assessment is typically ongoing together in collaboration between a social practitioner and our members. Next slide, please. And the last element of social practice is the transitional environments. I want to note that I did make an error when I said that the very first clubhouse was in Lahore, India. It was Lahore, Pakistan. And what I want to also mention, it was the Clubhouse model that essentially inspired psychiatric rehabilitation and the use of opportunities in the community, work opportunities to help people feel connected to their society. This was first introduced by clubhouses. So transitional environments mean exactly that. We move from essentially a clinical or mental health community or therapeutic community to the real world. Not that we were not in the real world, but now you're at a job. Now you're in school. Now you're volunteering in the community. Now you're interacting with other folks that may not be part of the clubhouse. And so it allows for us to design interventions that allow folks to interact with the broader society. It's very naturalistic. It invites us to engage in spaces and places that we may have felt we didn't belong. And now we have practice, and now we have a community, and we have support. And so we develop new identities, new roles to support purpose. And we experience as our success and our failures within this community. What clubhouses have traditionally had, something called transitional employment. These are opportunities for members to try out a job and see how it goes. And they move up the ladder in terms of how long they may stay in that job, for example. So it gives real world experiences. And so the next slide, please. So just to summarize, social practice is the therapeutic model that we are using in the clubhouse environment. This might be often the first place where our members are engaged in a therapeutic community, and maybe the first steps in reclaiming their identity, their agency, and their dignity. Social practice naturally tries to draw out individuals who may more likely isolate, be alone. And so members come for varying reasons, different motivations, but many people who come to Clubhouse come because they're looking for structure, something to do, and connection. Next slide, please. So what do we know after 40 years of Clubhouse research? Not all of those 40 years have been research that consisted of what we call in the sciences randomized control studies, which is the gold standard of a lot of our science. One of the very first randomized controls really established this model, and it goes back to the late 1970s. I know we're in 2022. Seems like, well, wow, that was a long time ago. But the model has always been something that was passed along through oral traditions, anecdotal studies. People were recovering and people wanted to know how and why. More studies found when we started doing later experimental studies in the late 90s demonstrated that the model had an impact on changing people's recovery trajectories. One of the more recent systematic reviews of all of the Clubhouse literature comes from our friend Colleen McKay. She's a director of research for Clubhouse research at the University of Massachusetts. And essentially, her and her team looked at all the studies and concluded the following results. Next slide, please. That essentially some of the robust studies coming out of Clubhouse research is this improves the quality of life for people living with severe and serious mental disorders. Randomized control studies have indicated that Clubhouse members significantly improve on measures of quality of life. Specifically, it improves a sense of empowerment, independence, or autonomy, and an identity of being person instead of patient. The second most rigorous, or actually one of the most notable outcomes that is often reported and cited related to this model is that it significantly reduces readmission and rehospitalization for psychiatric symptoms and episodes. And so a number of studies have really found this to be the central outcome for Clubhouses. It improves self-esteem, it improves their sense of being able to manage and live with an illness, which includes experiencing greater recovery experiences and not needing to go to the hospital every time an episode is experienced. The community, the management of the illness and symptoms has been reported to be really impacted by this model. And the third notable outcome related to Clubhouse participation is people getting involved in their communities through jobs and employment. Studies have shown that Clubhouse members tend to work longer, they're employed for a longer period of time, and they tend to receive higher or better pay when they're compared to people that are in other types of psychiatric rehabilitation programs. And so these three areas have tended to have the highest reported outcomes for Clubhouse studies. An area that we have begun to highlight is how Clubhouses have really supported the decrease in social isolation and loneliness. And so really understanding how Clubhouses have promoted a sense of unity and belongingness that really allows people to not feel isolated and alone. Next slide, please. In this slide, I've just sort of summarized the evidence from best evidence, good evidence, and with all good science, we need more evidence. And so we continually seek new projects and opportunities as a model that cuts across many cultures. We understand that although this is one of the most cost-effective models, it's one of the most simplest forms of interventions, but has some of the most profound and impactful outcomes on the lives of our members. So we have greater employment stability, higher reported quality of life, greater recovery experiences, greater social support, health outcomes. And so we continue to seek new ways to sustain this model in the US as well as globally. And with this, I'm going to turn it over to Dr. Lori again to bring us home. Actually, let me just finish. Oh, I was just going to introduce Module 3 with our star Dr. Aquila next week. And so this is just sort of a preview of what he will be talking about in really like, okay, so how do I get involved? What do we need to do? Module 3 will be talking more about how mental health professionals can leverage these community partners in their practices. And now I will take it to hand it over to Dr. Rory with our closing remarks. Thank you.
Thanks, Francesca. Just to summarize briefly so we can get to the Q&A, the Clubhouse model fills a void. As we've talked about, around the world, less than half, and in some cases it's very tragically even more than less than half of the people living with mental illness get any kind of treatment. And when they do get treatment, it's primarily medication, which is very important, but people need more than medication. They need a way to rebuild their lives. And this model has been ahead of its time, unfortunately, looking at a holistic and comprehensive way to help people recover that has been defined and driven by the people living with mental illness. So without further ado, I just want to help you all focus on the biggest picture that we're talking about here. This model is universally applicable. And our clubhouse in Ohio, in Cleveland, Ohio, reached out to clubhouses around the world and asked them to submit some pictures. And we put together a little snapshot of some of the clubhouses around the world. I hope you enjoy it.
Thank you, Dr. Pernice, Dr. D'Angelo, Craig, and Lisa for sharing with us about Clubhouses. And I just love that video. I feel like even in my short time with Clubhouse, I've actually met some of the people from around the world, and it just blows me away that, you know, the foresight of 4 people in 1944 could have created this international movement that really supports people. And I just want to say, as a new staff at Fountain House, you know, when you look at all those pictures, it's impossible actually to tell who are members and who are staff. And for me as a psychiatrist, one of the lucky few psychiatrists that are working in the Clubhouse movement, I think what struck me is how much I've grown as a person through my own, you know, path, just being part of a community where people all support each other, people all find the need to be needed and the belonging in this community. And what a reward it has been to work with this team and with everyone involved. So I hope you've you know, really felt that today. And not only felt that magic, I really hope that everyone will have a chance to experience the Clubhouse through a tour. You're always welcome at Fountain House. I will arrange your tour myself. But not only just experience that magic, to really understand through what Dr. Pernice shared with us, the science behind why this works and why this is important. I'm really happy to take us into the panel discussion, now moderated by Kevin Rice, who was a major developer of this curriculum. So passing it back to IVCI first to give us instructions on the panel discussion.
Thank you, Dr. C. For those that have a question they would like to ask, please submit your questions in the Q&A pane, the icon of which can be located on the bottom of your Zoom window. With Kevin helping moderate today's Q&A, we'll go ahead and pitch off our first question, which I believe will be for Dr. Javed. Dr. Javed, where will this recording be available and when will it be available? I believe you may be muted, Dr. Javed.
Sorry for that. Thank you very much for this question. We are currently working on it, and we are looking at the logistics. So hopefully, once all modules are completed, then we will add this to WPA's educational portal system, which is free, and that also includes many other educational modules relating to mental health. But this is very important for us, and we will work with the Fountain House New York organizers of these modules, and hopefully we will be able to add to our educational portal very soon. And this will be free for anyone to join and to see.
Excellent. Thank you, Dr. Javed. Our next question is, why do people come to Clubhouse? Kevin, I'll pass that to you to assign out.
Well, I think the best people to answer that would either be Craig and Lisa, and then maybe others have thoughts, but maybe Lisa, could we start with you to answer that question, and what kind of was the initial appeal for you?
The initial appeal for me is I was a person, I've been living with mental illness for over 40 years and was not properly treated until within the last, I'd say 8. But for Clubhouse, for me, I was convinced. You know, I lived in my home for 15 years, did not have any outside contact. I had no family contact. I was very, very, very isolated, hospitalized many times, different medications through all this time. And when they finally convinced me to go into Clubhouse, I was so scared. But when I walked in that door, I was just overwhelmed with how I felt like a family right off the bat. Everybody was just welcoming to me. And you know, it took me about a year to really integrate and become personal, but I have so many friendships there now. It has provided me with a platform to be public, to write legislatures, to do this, to further my education, to be able to patient advocate. There are so many different things, but the Clubhouse model has kept me out of the hospital. I have not had not one hospitalization since I started the Clubhouse.
Craig, maybe I can ask you a follow-up question to that. Would you say
Certainly.
that why you engage with the Clubhouse now, is it different or is it the same as when you initially engaged, or was there an evolution to that?
An evolution was an evolution. I came in as a very scared person and still did not want to trust people, even though it was very welcoming at first. I was just afraid to trust what was there because I had been disappointed so many times throughout my life. So it was definitely an evolution.
And what about you, Craig? And can you add any from your experience?
I just wanted to add that Clubhouse has given me a great sense of purpose and community, and that it's helped me to channel my creative and political energies for advocacy for the mental health movement. So it's been very important for me. I wanted to add one more thing, and that's I wanted to thank Dr. Panice and Dr. Javed. They're not Clubhouse staff. They voluntarily support this movement and model. They don't have to be involved with us, never mind publicly support us, and I just want to thank them for their service.
Thank you, Craig. Moderator, can we go to the next question?
Certainly. Can you please describe more of the job descriptions, roles, and training of social practitioners' care of workers, how they are trained, and are they paid?
I'm going to pass that one to Dr. D'Angelo to answer.
Thanks. Yeah, people that work in the Clubhouse come usually with a mental health background or experience and often are social workers, but they can have various levels of credentials and can have no credentials. And the training varies, but the social practice training is a newer development that we're having more and more people within the Clubhouse network exposed to. So they have more of a framework for what they've been doing and a better way to help train newer people in the work. Kevin, do you want to add anything to that?
I think the main things I would add is the principles are kind of are trained through I was a social practitioner prior to my role as a research director, is that you receive best practice training from the institution itself while you come into it. So while you may have a mental health background and an expertise, either that's with clinical populations or other types of cases, the community helps kind of acclimate you to this different model, which is quite radically different from those other settings. And members and legacy staff members are the ones who are involved within that. And so one of the goals within this kind of goal of this curriculum is also to kind of offer that framework for other healthcare professionals with partnering with it. But also there's a larger kind of movement, as Dr. D'Angelo said, with social practice training and formulation of the intervention practices for within the community itself.
I'd also just like to add, there's Clubhouse training that's been developed by Clubhouse International and clubhouses around the world that is part of the standards, the requirement for members and staff of clubhouses to be engaged in that training. So that's been in existence since the late 90s. So that's something that everybody has and continues to engage in as well.
Yeah. And the last thing I will mention is there's kind of a rewiring also that you undertake when you participate in Clubhouse as a social practitioner. That kind of precocious caregiver helper instinct is something that you maybe lead in with, but then you withdraw from as you try to help the member either take on the work or whatever involvement they have for themselves, get reconnected with other relationships than just the one-to-one one that maybe you started with. And so that kind of centralization of you as the primary kind of support is something that you kind of unlearn to a certain extent. And you also are constantly having to check yourself with the equity and power dynamic that is quite often maybe something that you experienced in prior kind of either educational or practice settings that is very different in a clubhouse. And so that kind of training is, there's always kind of supervision that happens between social practitioners, the people that are supervising them, always checking in, and also feedback from the community itself, assessing how they feel like we're living up to those standards and whether or not the staff, the members, the programs are really providing the needs of what that local community is seeking. So there's a lot of mechanisms to kind of not only establish a baseline of training, but a continuous assessment and quality control of that over time that the membership and the broader community is really involved in as well. I think we'll go to the next question, moderator.
Thank you. So today we have a nurse on from the Philippines, and she would like to know, is there any groups that I can join to be affiliated with Fountain House?
I will pass the one to Dr. C to maybe answer how she might be connected.
I actually think that possibly Dr. D'Angelo or Dr. Pernice has more expertise on this. I know that Clubhouse International has a very good website that you can navigate to and provides information about clubhouses around the world, as well as links to how you can form your own clubhouse where you are and how you can get more information about getting involved with Clubhouse. Do other folks have anything to add to that?
I would say directly approach the Clubhouse if you're interested in it. You don't need a support group to get involved. Contact Fountain House or whatever Clubhouse is in your community, and they'd be more than happy to give you a tour and other information you need.
Okay, moderator, can we go to the next question? Yeah.
Thank you. Can you elaborate on how the Clubhouse model addresses social determinants of health? It seems that the Clubhouse movement understood the social determinants of health before it became a commonplace.
I'll pass the one over to Dr. Pernice, and then I'm sure others will have some contributions there around social drivers of health.
Well, that's a really good question. Here in the US, we've been talking about social determinants of health in terms of, housing, employment, education, socialization, transportation. And I'm going to include Dr. Eric in this question too. How has this really, how do you see the impact Clubhouse has had on these areas?
Yeah, thank you, Dr. Pernice. I would just highlight just one thing that I've seen in the community where I live. Many of our individuals that we work with may be living in a housing situation where they actually have to spend significant portions of the day outside of the home, the adult foster care home or some of the other living arrangements. They need to be in the community for a number of hours. And without Clubhouse, where is someone going to go? How are they going to spend that time? How are they going to make good use of their day? And I think about how Clubhouse fills such an important role there for members and gives them, again, what we talked about, relationship, purpose, community, and a real opportunity to grow in those hours. I have some individuals I work with who are not Clubhouse members, and they really struggle to fill that time. They may go to the library for a few hours or to a store. They don't have the same kind of purpose and structure that our Clubhouse members have. And of course, that always impacts the other social determinants. You have so much support within Clubhouse to get rides, maybe to medical appointments or support for social activities. The business unit, as Lisa talked about, helps people prepare and write resumes, have these job opportunities that are so key to a sense of purpose and moving forward. So I could go on and on about the ways in which I think Clubhouse really impacts all of those social determinants, but I'll stop there and let others jump in.
Dr. Javed, did you have something to add? Yes.
Well, I think I would prefer using the word socio-cultural determinants rather than only social determinants. The reason being because there are so many different cultural expectations when we look at globally. Just to give you an example, in many countries, especially the low and middle income countries, the independent accommodation may not be a priority because there is always a family to look after these people. In some countries, there may be a sort of employment, independent employment, so that these people who have got these chronic mental illnesses and who have gone through the doors of Fountain House or clubhouses, how can they become independent and empowered in terms of the finances? So probably there is no hard and fast rule in terms of the determinants. The determinants need to be determined as per the socio-cultural needs. And it could vary from one place to another place, one country to another country, one culture to another country.
Yeah, I'll build on that and just kind of add that you may meet these kind of social cultural needs or provide supports around them, but then the question is for what, right? I have a job, but for whom do I share the successes or the benefits that I get that job with, right? The money that I accrue or the status that I achieve may have secured employments or kind of certain levels of kind of social security. But then I think what Craig and Lisa really highlighted was this sense of purpose that either maintains or sustains the relationship to those supports, that it's not just kind of an end unto itself to have the support, but then there's this aspirational, certain kind of personal life trajectory that becomes oriented around relationships, confidence, and kind of a hopeful future that then maintain those things over time in a really long term. That's where that membership for life kind of comes in, as Dr. Panici says, where maybe someone's not having the same relationship with the community over that entire time, but the community persists, right? And that's the thing that has that thread of purpose that is always able to offer as a buttress when times maybe are hard, and help kind of reinforce people's support networks, and also as a place to celebrate when times are going well, and to maintain that. And I think that's one of the key things where we can maybe throw a lot of money about supports and just getting people connected with supported jobs and housing and things like that. But that core community dynamic, I think, is the other thing that is really unique that a lot of community programs, not just Clubhouses, contribute, and we're trying to better understand and study through research. Lisa, I see that you have something to add as well.
Yes, I think as far as, and I've said this many times and other things, I also think it's most important for people to understand that the Clubhouse model is a bridge. It is a bridge between our psychiatrists, our therapists, because they're not always, they can't be there to help us 24/7. We only get to see them a certain length of time, you know, like an hour, maybe once a month, or the psychiatrist every 3 months. They're not there to help us develop our personalities per se, but the Clubhouse model meets that gap.
Thank you, Lisa.
Quickly before we go to closing, Dr. Javed, we do have one final question for you. How can someone become a WPA member?
Well, our membership is primarily open to psychiatrists, but there is a provision that other mental health professionals other than psychiatrists can also apply and become individual members. I personally feel, and this is what I'm encouraging to all our 145 societies globally, that they must have some provision of taking patients, carers, and users on board. So this is not only a sort of an association which is offering services to psychiatrists or mental health professionals only, but we should also have our carers, patients, and families with active participation. For example, in the current WPA structure, I have created a special task force, a group, a working group, which is having a liaison with the patient, carers, and users all over the globe. So you are always welcome to come and join us, or at least just visit our website and see that what sort of activities we are offering. But I must say that the program, for example, the Fountain House, this module, which has been prepared primarily by Fountain House, New York, is just an example how WPA wants to promote mental health, management of mental health, and bringing dignity and belongingness of our patients back to them.
Thank you, Dr. Javed. Dr. C, I'll pass it over to you for closing remarks.
I just want to thank everyone for joining today, and I hope you are as excited about Clubhouse and community-based supports and its ability to enhance our work as I am. Thank you, and please do join us for Module 3 next week, where we'll talk really about how psychiatric providers can partner with clubhouses, how that is done to more detail, and we will have Dr. Ralph Aquila joining us for that discussion as well. Very excited about that. All right, thanks again, everyone.
Thank you. If we have not answered your question today, please feel free to send an email to pic@fountainhouse.org. An upload of this webinar will be made available on fountainhouse.org in the coming days. Thank you all for joining today. You may now disconnect. Have a wonderful day.